on our time and the people that connected early. I would like to welcome everyone to this third colloquium of the Andromeda Research Network. As you know, um, this is an opportunity for us to meet, to connect, to strengthen our relationships between all the researchers of Andromeda and also people that are coming and being part of this community. So this idea is not only to share science, but to share experiences within it, everybody to get to know each other, to discuss these hot topics on critical care research and clinical aspects of hemodynamics and septic shock. And today I have the honor to present a close friend, Oliver Hunsicker. He's professor, PhD in Charité Berlin, in the one of the biggest hospital in Berlin, and a great researcher and a true friend that we've been working together in the last, I'd say, couple of years, but in the last year, very, very closely. And today, Oliver will, in the next presentation, will show us, he's an expert in echocardiography, and we ask him this topic that's very thought-provoking and interesting called echocardiographic phenotyping in septic shock, integrating hemodynamics for personalized resuscitation. So, Oliver, thank you very much for being with us. We have a nice audience. We're also recording this presentation, so we can later put it in the repository for people to enjoy it asynchronically. And please, the stage is yours. And welcome to the colloquium.
So, Eduardo, thank you, first of all, for your very nice words. And yes, we are working now very close together, and I think this is great. And thank you so much for the opportunity to give this short lecture today on echocardiographic phenotyping in septic shock. So, first of all, I've no conflict of interest on this issue, and I would like to start with a paper that was published many years ago. It's a publication from 1965, and it was submitted by or published by Robert Wilson and his group. And these people were one of the first groups that systematically assessed hemodynamics in patients with septic shock. And what they did, they compared the hemodynamic measurements they obtained with patients in cardiogenic shock and in patients with hypovolemic shock. And one of what they did, one of their results was they plotted cardiac index over central venous pressure and connected the patients of the different shock types together. And what they found was very surprising at this moment in 1965. They showed that septic shock is not a uniform hemodynamic condition, but it's more like a severely heterogenic conditions, and it overlaps, or these patients with their hemodynamic characteristics overlap with those in cardiogenic shock and even those of hypovolemic shock. And this was very early findings, and because before septic shock was also thought that it might be a shock of a low cardiac output. And now they saw that the patient have a high variability regarding the hemodynamic conditions. Now, a couple of years later, in 60 years later, we now published this very nice paper. It's just a preprint, an article in Press, and it summarized and reflects the last 25 years of septic shock resuscitation trials. And during this episode, after major resuscitation trials, we also learned step by step that a multimodal assessment is necessary to capture the full heterogeneous hemodynamic picture of our patients. And one of the major tools that we now know, of course, is echocardiography. And echocardiography in the 1990s was usually a tool that was used in the operation theater in patients undergoing cardiac surgery. And it was used as a monitoring tool. And now during the last couple of years, it evolved as a very powerful tool to be used at the bedside in patients with shock and especially in patients with septic shock. And what we know from the last recommendations 10 years ago, they stated that echocardiography is the first line imaging modality in patients with shock, in undifferentiated shock. And now the new recommendations, which we published in November last year, they go beyond that. They state different things, and this is what we have a look now. Echocardiography is mentioned in the hemodynamic monitoring section, and echocardiography even has its own domain in the new guideline. And the new guideline clearly states and confirms that echo is, of course, the first-line imaging modality in all our patients with shock, especially those with undifferentiated shock. And what is new is that we say that serial, so repeated echocardiography assessments should be done because they will provide additional information we will not have from a continuous cardiac output monitoring. And this is why the guideline states that it should be done even when cardiac output is monitored. But the question, and when we talk to colleagues, they always ask, what about the outcomes of our patients when we use echocardiography in patients with shock? And this was also one of the questions in the new guideline. And we cannot really say something about that. There are signs that the use of echocardiography at the bedside is associated with better outcomes, but the evidence is still limited. I will show you a couple of publications. These are the most important ones published during the last couple of years regarding the use of echo and short-term outcomes. What we know is that the use of echocardiography will shorten the time of resolution to shock. When we guide our management using fluids and inotropes, there are signs that the use of echo will improve survival at 28 days. And especially in septic shock, we have first data that early echocardiography, so done within the first day after the diagnosis of septic shock, is associated with a decreased 28-day mortality. Of course, these data are still limited, but I think it is a clear sign that echocardiography might improve outcomes. There's one meta-analysis, one recent meta-analysis published at the end of 2024 that put together a few studies where POCUS was done, and the major modality in POCUS was echocardiography. And they also found that there are at least signs that POCUS and echocardiography will reduce mortality at 28 days. Let's go back to the guideline. What does the guideline also states? It says clearly that echocardiography will support or is supporting our clinical decision-making at the bedside because in many patients, it leads to changes in management at the bedside. And one of the last statements, and this is very, very new in this guideline and never happened before, is that we have now some data that echocardiography defined phenotypes of right and left ventricular dysfunction might be of prognostic significance. And I think this is the topic of today. We recently published an international survey on echocardiography and the use of echocardiography at the bedside in critical ill patients. And I think what you can clearly see, participants from over 62 countries, they clearly state that echocardiography will help to diagnose several conditions, maybe several phenotypes. And it helps, of course, to monitor our patients at the bedside and should be incorporated in our clinical work. However, we are very surprised when the new sepsis guideline was published a couple of weeks ago. And the new surviving sepsis guideline of 2026 has 74 pages. And we were very surprised that echocardiography was only mentioned twice in the whole manuscript. once in the section fluid resuscitation guided by dynamic management, and once in the use of inotropes. And this led our group, the ESICM group of Advanced Critical Care Echocardiography, the EDEC group. It lets us to write a letter, a correspondence on these guidelines, because we know it's important, or we think it's important, to raise our hand and to clearly say that echo is an essential component in the comprehensive assessment of our patients, especially those in shock. And I will tell you why. Echo is not only a functional hemodynamic management. Of course, we can measure cardiac output, we can measure different other echo variables, and of course we can use echo to provide functional tests, such as assessing fluid responsiveness, doing passive leg raise test to assess fluid responsiveness. But echo is more. It also provides us anatomical information, and I think this is critical because this can only be done by echocardiography. You can reveal cardiac dysfunction. It identifies morphological pathologies. And of course, and this is critical, identifies dynamic pathologies. And something which is often forgotten when I talk to other colleagues about echocardiography, it's not only the functional and anatomical information we get. Echo is a tool of validation. It contextualizes the clinical findings, putting everything together and see if it's plausible what we have seen at the bedside and what we now see in echocardiography. And I think this is very important, it validates by adding imaging to numbers, to what we really measure in our vitals or advanced hemodynamic monitoring. So overall, echocardiography has the power to integrate everything at the bedside. And it's not just about echo findings, it's about integration by echocardiography. In patients with septic shock, we would like to think in phases. I think everyone knows the ROSE or SOSD concept, with resuscitation, optimization, stabilization, and evacuation phases. And echocardiography, of course, has its place in the different phases. In the resuscitation, especially in the very early resuscitation phase in patients with septic shock, we would like to use echo as a really basic tool. And of course, the Andromeda algorithm was not applied in patients with very early septic shock. All of them had at least 1.5 to 2 liters of fluids before patients were included into the study. But even then, it was important to have a look at the heart. And this is an overview about the algorithm when the patients had completed tier 1 and the CRT was at this point still not normalized, then they underwent echocardiography, so very early echocardiography. And what we saw in the Andromeda 2 shock trial was that about 30% of the patients in the intervention group reached that time point and were scanned. And very interestingly, also 1/3 of these patients that were scanned, they had LV or RV dysfunction, as characterized by a very low LVOT VTI, so a low stroke volume, and a low LV fractional area change. Or if they had right heart failure, they were diagnosed by RV dilation and increased CVP. And if we summarize that, according to the 720 patients in the intervention group, we saw that 1 out of 10 patients, or 10% of these patients had cardiac dysfunction. And one example is like this patient, and this was also an Andromeda patient in a very early stage. And as you can see, the patient has a very severely reduced LV function, as seen in the 4-chamber and 2-chamber view, and even, of course, in the short axis, with a very low VTI of 10 to 11 centimeters. So this is an example of a patient in this very early stage with a severe LV dysfunction that need to be identified because it need to be treated differently compared to patients that have not an LV dysfunction. And when we go into the Andromeda supplement, into the results in the supplement, then we discover that the patients that had LV or RV dysfunction and received specific therapy, 1/3 of them, so the CRT responders, normalized the CRT within the given time frame due to a specific treatment. But more interestingly, even in the group of patients that did not reach a CRT normalization at the end of the study period, or the algorithm, even those patients had a reduction of the CRT, so an overall improvement. So I think that confirms that it's important that echocardiography is used very early because these patients need to be identified and they will benefit from a specific therapy, whatever that is. When we go to the next phase, when we leave the very early resuscitation and more go to the transition to the optimization and optimization phase, we know, of course, that we have 3 major pathophysiological mechanisms, which are hypovolemia, vasoplegia, and of course, cardiac dysfunction. And I think echo can help to put these pathophysiological mechanisms into a phenotype at the bedside. And there's, in my opinion, one landmark trial that clearly shows how to do that. That's a trial that was published now 7 years ago in ICM and included 360 patients with septic shock. It was done by Antoine Villabaron and his group. And they pooled 2 prospective databases and had 18 ICUs where the patients were treated. And they did transesophageal echocardiography in these patients. And all these echoes were done within 12 hours after the diagnosis of septic shock, so early. And these patients, and I classify these patients in the optimization phase because they had at least 2 liters of fluids before, so it was not early resuscitation. But very important is when we look in the methods of the study, we see that they excluded patients with chronic heart failure. And what they did is a hierarchical clustering analysis using echo variables, but not only echo variables. They also used vitals such as heart rate, systolic, diastolic pressure, mean arterial pressure, and even vasopressor doses, which are not shown here. And they identified different phenotypes. And the first phenotype in about 17% of the patient, so 1/5 of the patient, they had normal echo variables and normal vitals. So normal ejection fraction, a normal stroke volume, and the patients were not fluid responsive. Then they identified a second phenotype, which they called the LV dysfunction. Now we can say cardiac septic cardiomyopathy, even if there's no consensus definition so far. But this LV dysfunction phenotype was characterized by a decreased ejection fraction in this study, around 30% ejection fraction in these patients, a severely reduced LVOT VTI around 11 centimeters, so a severely reduced stroke volume. The patients were not fluid responsive and had more or less normal right to left dimensions. Then as a third phenotype, they discovered the patients with RV predominant dysfunction, and these were also around 20% of the patients. And these patients were mainly identified by an increased RV to LV diameter or ratio. And these patients had a normal ejection fraction which is commonly the thing, even in patients with right heart failure, and they were not fluid responsive. And then there were two more phenotypes they identified. They called it the hyperkinetic state, also a rate of about more or less 20% of the whole population. And these patients in hyperkinetic state had a supranormal ejection fraction, a supranormal left ventricular fractional area change, and they had an increased stroke volume as shown by the increased LV VTI. And these patients were not fluid responsive as seen by the variability of the superior vena cava variability. And the last phenotype they identified, they called it still hypovolemic. And at the first sight, these patients that were still hypovolemic, which were also about 20% of the whole population, they had comparable LV, supranormal LV ejection fraction, but they had a very low stroke volume, and the variability of the superior vena cava as a measure of fluid responsiveness told us that these patients are highly fluid responsive, and this is why they were called still hypovolemic. And I think this is really a landmark study that improved our thinking about different phenotypes in septic shock. And just to give a few examples on that, this is a patient that we would classify as RV dysfunction, as you can see, with an increased right ventricular diameter, with an increased RV to LV ratio, in this patient more than 1:1. That was a patient with ARDS. And on the right-hand side, you can see the short axis with a clear sign in this patient of a paradoxical septal motion. So this patient is a patient with acute cor pulmonale and would be classified as RV dysfunction in this hierarchical cluster setting. Then this is a very good example of a hyperkinetic state. This is a patient with severe vasoblegia in septic shock. And as you can see, a supranormal ejection fraction of about 70 to even 80% in this patient, combined with the LV VTI measurement that was also supranormal in this patient, around 26 centimeter, which shows us that this patient has an increased stroke volume. And this patient was not fluid responsive when we tested it. So this patient will be classified as hyperkinetic state. And in contrast, this is a patient that we would classify as still hypovolemic, also has a supranormal left ventricular ejection fraction, but when we assessed him at the first time, he had a decreased LVOT VTI, as seen in the upper right picture. But when we gave him some fluids, and after successful fluid testing, we saw that the patient increased the stroke volume around 30%. So this patient is highly fluid responsive and would be classified as still hypovolemic. And when we go back to the publication and have a look at the different ICU mortalities that were shown in this paper, we see that there's a significant differences. Patients that were normal, that were also called well resuscitated, had the lowest in-hospital or ICU mortalities, whereas patients with LV dysfunction had the highest mortalities. Also very high mortality among patients with RV dysfunction and those patients who were still hypovolemic when they are assessed by transesophageal echocardiography. And this finding that patients that have a supranormal ejection fraction and patients that have a decreased or severely decreased ejection fraction was confirmed in this very nice study by Duger in 2023, when ejection fraction was plotted over adjusted odds ratios for in-hospital mortality, and clearly showed this U-shaped curve in patients with septic shock and higher doses of norepinephrine. So it clearly confirms that patients with severely reduced as well as patients with increased, most probably due to severe vasoplegia, have increased mortalities. But there's more. There's more. There's one subphenotype that is very important and, in my opinion, can only be identified by echocardiography. And this is the state of intraventricular obstruction. We know from a publication in 2025 from Michel Slama and his group that intraventricular obstruction is a very frequent event in septic shock. And it's not only the LVOT obstruction, it's even more the midventricular obstruction that is important in this patient. So are there different positions where the obstruction can occur in the left ventricle? And I think the most important thing is that we know from these data that this often happens in small, hypovolemic and hypercontractile left ventricles. And as I said before, we need the echocardiography to identify this dynamic pathophysiological mechanism. And one major finding also from this study from Michel Slama was that almost every patient with an intraventricular obstruction is fluid responsive, and fluids is the cornerstone of therapy in these patients. And there's a very nice publication by the group of Mateusz Sawatka, which was published this year, and clearly shows like a concept how to scan these patients and how to screen for intraventricular obstruction when we first apply a color flow mapping or a color Doppler to see the flow turbulences in the LV or in the LVOT VTI, which is then followed by applying a Doppler, a CV Doppler, to screen, and hopefully when it is when the patient has intraventricular obstruction, then we most probably see like a dagger-shaped sign, so a late peaking gradient. And then if we have identified such pathology, then we can, of course, diagnose more in detail using PV Doppler to screen the left ventricle and see where the intraventricular obstruction really takes place. And this is a patient, a septic patient, hypovolemic, and who has the pathology of intraventricular obstruction. You see this supranormal ejection fraction, and you see these kissing walls in the short axis and in the apical four-chamber view. And you clearly see in the right picture on the bottom where we have the CV Doppler curve, then you see that it's more dagger-shaped with a late peaking gradient, which all the things taken together is a clear sign of a patient with intraventricular obstruction, and this patient clearly needs fluids and clearly needs more afterload. But there's one last phenotype, and it's very nice explained in this editorial I very like from Antonio Messina and also again from Antonio Villabaron about the phenotypes in septic shock. And they came up that there's one more, which is the ugly one. And I think you all know this great movie, and this is image from the publication, the good one, the bad one, and the ugly one. And I think it's clear the good one, these are the patients that are well resuscitated and have more or less normal hemodynamic parameters after resuscitation. Then we have the bad one, which we have talked about in the last couple of minutes. But there's also the ugly one. And the ugly one is a very difficult one. And those are the patients they have acute on chronic cardiac conditions. So the patients that have pre-existing cardiac abnormalities. And this can be very challenging. For example, patients with ischemic heart disease and who are after myocardial infarction, where we do not often have previous images or loops or or written reports. So we don't know what is new in patients with septic shock and what is not new. The same is patients with heart failure with reduced ejection fraction, with dilated ventricles. Then we have patients with valvular pathologies, like in this patient with amyloidosis and a severe mitral regurgitation. Then we have patients with stenosis, as in this patient, with a severe aortic aortic stenosis, or in the last patients, this is the patients after TEER, so after mitral valve repair. And all these pre-existing cardiac conditions make the situation more complicated, because often we do not know what is the baseline of the patient and what is new due to septic shock. And why is it so important that echo supports the hemodynamic phenotyping in our patients? And why it's important that we identify the different phenotypes? It is important because the patients will be treated differently. Of course, patients that are well resuscitated after early resuscitation, that these patients, of course, need careful re-evaluation. Patients with LV dysfunction, they, of course, and this is what we know at the moment, they need sepsis control. Often the infectious source is not controlled if they have severe LV dysfunction. And of course, they need a careful assessment of fluids, vasopressors, and inotropes. And I think we need some more data how to really treat these patients. And there's the ADAPT trial, hopefully will be published in the next couple of months, that will also improve our understanding of these patients, if they need inotropes or not. Then we have the patients with RV dysfunction. And of course, in these patients, we know that we have to maintain pressure, because the right ventricle really needs oxygen. Maybe we can support these patients with inotropes or inodilators. We have to think about the ventilation of our patients. And most of these patients are ARDS patients, and most of them will benefit from proning, especially for the cardiac situation. And we have some very good data published in the last couple of years that proning is really a therapy to improve hemodynamics. Then we have our patients, as I said, the ugly ones, acute on chronic cardiac conditions. And it's clear that these patients really have to be treated individualized. And I cannot tell you a specific therapy that has to be discussed, of course, at the bedside in each patient. But I think it's important to know about the hyperkinetic state, because I think this is critical. And I think we have now improved during the last couple of years, especially, of course, when we had the results of the Andromeda studies. And this was also the thinking of the Andromeda studies, that we have to avoid over-resuscitation. And this can especially happen in these patients, especially when we do not have identified this phenotype. Because when we see these patients at the bedside, they have a high heart rate and usually appear to be fluid responsive, but these patients are not. And I think it's very important to avoid over-resuscitation, which does not mean that the patient will not receive fluids until the next morning, but not that aggressive one as patients that will benefit from fluids. And patients that are benefiting from fluids are those that we classify as still hypovolemic. These patients need fluid resuscitation, need aggressive fluid resuscitation, but of course, we have to start testing. And this is very clear from the sub-analysis of Andromeda 1 published by Glenn Eduardo and the group, where they showed that patients after initial resuscitation, most of them, 70% of them, are fluid responsive, but the rate of fluid responsiveness decreases very, very fast during the next couple of hours. So it's important to test fluid responsive even in these patients. And I think this is like a short overview and a rationale why echo is important and why echo should support identifying phenotypes at the bedside. And as I said, the subgroup of patients that are classified as still hypovolemic are those with interventricular obstruction. And this is a very special patient population because in this patient, of course, we have to avoid using inotropes. We have to increase the afterload and often have to control tachycardia because they will benefit from a more or less normal heart rate. Let's have a look into new data published in patients in sepsis and some of them in septic shock. And this is a study that was published in July this year, so a couple of days before. And I think it's very interesting because we have the landmark trial from Baron, and these are now new data, and I would like to go through this data with you in detail. This is a study with 1,799 patients, and it was done in a two-step model. First, there was a derivation cohort to come up with septic or with phenotypes, echocardiographic phenotypes, and then they did a second step, they did a validation. And it was a retrospective single-center trial. And when we had a look at the table 1 in this paper, we saw that only 18% of these patients, of this large population, were in septic shock. Lactate was about 1.5 millimole per liters. Vasopressors were used in 57%, and almost 60% of the patients were ventilated. Very crucial is when echo was done, it was done on day 3, so rather late than early compared to all the other studies before. But the same as the landmark trial, they excluded patients with chronic heart failure. So no chance to have a look at patients with acute and chronic, the ugly ones. And when we had now a look at the clustering approach, we saw that they also used echo data, standard echo data as ejection fraction, as the ratio of the right ventricle to the left ventricle. They used heart rate, so vitals again. They used their LVOT, VTI, and cardiac index, and further determinants of right ventricular function. And very interesting, they also came up with very similar phenotypes, but of course, the prevalence of the different phenotypes was different. They observed that a normal function and vitals were seen in 56% of the patients. They also identified by their clustering approach a population with LV dysfunction. And these patients were also characterized by low LVOT VTI, as you can see in the left image, and a low ejection fraction and normal RV to LV dimensions. And those patients, of course, had a high systemic vascular resistance. But in contrast to the Gary paper, only 10% of these patients were classified, or of the population was classified as LV dysfunction. The same with RV dysfunction, which were mainly characterized by the increased ratio of the RV to the LV, but also just 10% of these patients had RV or were classified as RV dysfunction. Of course, the study could not argue on acute and chronic because they also excluded patients with chronic heart failure. But they also identified a phenotype that is very similar to the hyperkinetic state phenotype with an increased stroke volume, as seen by increased LVOT VTI, and a supernormal ejection fraction. But in this study, they did not test fluid responsiveness, so we cannot say if all these hyperkinetic patients are real hyperkinetic and not fluid responsive, and we cannot state anything on the cluster of still hypovolemic, as Gary and Baron has done in the other study. When we have a look at the mortality in these patients, and remember, most of the patients were in sepsis and just almost 20% in septic shock, we saw that patients that had normalized had normal hemodynamic values had a mortality of about 18%. And also here, the patients that had cardiac dysfunction, LV or RV, had a significantly higher mortality compared to the normal ones. And even here, the hyperkinetic patients, they also had a significantly increased mortality. Then we have one further study, which was also published this year, also on echocardiography phenotyping in patients with sepsis. And be careful with this study. I will show you this study, and I think it's important to have the study, but be careful with the interpretation, because in this large study with 2,000, a little bit more than 2,000 patients, 1/3 of the patients were not on the ICU. This was a trial where patients were identified in the emergency department, and then if they improved, they did not go to the ICU, but or went to the normal ward. So 1/3 were not treated on the ICU during the further course. We cannot argue anything about septic rate of septic shock. It's not given in the manuscript. What we know is that lactate was comparable to the previous study. Vasopressors were only applied in 50%, and only 40% of the patients were under mechanical ventilation. The TTE was done on very comparable day. Previous was 3. This was done on day 2, so not very early, but not very late. And they also excluded patients, again, with chronic heart failure. And on the right-hand side, you see the phenotypes that they identified. So pretty much the same phenotypes, normal RV, LV, RV, and the hyperkinetic state, but with a different prevalence or incidence compared to the landmark trial and the previous trial I've shown you. And I think this is clearly or well explained because these patients were not as sick as the populations before. And this is also seen in the mortality that is given here. The in-hospital mortality in this study was also not that high as compared to the previous study. And I'm not really sure about these mortalities because I think it's not in my mind that the LV dysfunction will have the same mortality as a normal study, but those are the results that came from this trial. Let's have a last look on the trajectories of LV and RV dysfunction as identified by echocardiography over time. And this is also a very new study published in November last year and gives us an idea. And I think not the incidences are important here, but the trajectory. And what we see here, these are the first 3 days on the x-axis, which are displayed here from sepsis onset to the diagnosis or to the echocardiography and then to the diagnosis. We see that there's a parabolic trajectories. So it increases over time and peaks at 2 days. And this is well aligned with previous studies that showed that, of course, LV and RV dysfunction can occur very early in septic shock, but more often occurs after a delay of 1 or 2 days. And as I said, please do not have a look on the specific rates of RV and LV because the criteria are a little bit different, not that strict as applied in the hierarchical clustering approaches. So I think we can conclude what we know and what we do not know so far about echocardiography phenotyping in septic shock. I think we now know that echo is an essential part when we assess our patients with sepsis and septic shock. And we do not only have now data on the different phenotypes and rates in septic shock, we also have more and more data in patients in sepsis. And I think this is important for our understanding. And it's important for us that the studies in sepsis more or less confirmed the phenotypes that were shown or were found in septic shock. I think we need to have more data in the next years to improve, of course, our understanding, not only on the characterization of these patients and come up with clear criteria, but also on the trajectories and the benefit to our therapy. And of course, a blind spot we have so far are the data that we call the ugly patients, because those are those with acute and chronic conditions, and they're very difficult to assess and to treat at the bedside, and a real challenge for us. And as you have seen, all the data, even the most recently published papers on that, they excluded these patients. And I think this is a very important research question for the future. My last slide, coming back to our data that were published 60 years ago. And I think you were also thinking about now how we can apply our echo phenotypes on the data that were published in 1965. And I tried, and I hope you will agree with me. Otherwise, I'm very happy to discuss with you. And thank you very much for your attention. And again, thanks to Glenn and Edo for the invitation. And I hope we have a great discussion now. Thank you very much.
Thank you, Oliver. That was a wonderful, wonderful lecture. I enjoyed from the beginning till the end. It was very eloquent and with very, let's say, updated data and the perspective in which was constructed. Not being an echo expert, I enjoyed it from the beginning to it. So thank you very much. I have many questions, but maybe we can open the discussion to the audience if they have questions for Oliver, and I'll keep mine for the end. Because I'm very, very interested just on the hyperkinetic state. I think that's also a very unexplored from a therapeutic perspective. So we have some time now for some discussion with the audience. I don't know if there's any questions. Hi, Glenn.
So we can't hear you.
Yeah. Okay. Do you hear me?
Yes.
Now.
Thank you. Thank you so much, Oliver. I am very pleased to have attended this lecture as the same as Eduardo. I am not an echo guy. I only, when I look at the echo screen, I only see shadows, because I am too old for that. I am a guy that was born and started practicing critical care in the era of the Swan-Ganz catheter. I remember I put hundreds and hundreds and hundreds, I don't know, maybe thousands of Swan-Ganz catheters in these early decades of my practice. And when I realized how echo has influenced our practice over the years, as we put in this paper, the 25 years of septic shock resuscitation trials. It's amazing. I mean, your lecture was brilliant. I enjoyed it so much. But comparing with, maybe it's unfair because you compare with what we did in 25 years ago, maybe. But the info that the pulmonary artery catheter gave us, provided us, was, when we look back and compare to the echo now, is so limited, so limited. It was so limited. It still is, except in certain conditions, of course, that is still useful. But let's say in right ventricular failure, what's said, pulmonary pressure, etc. But compared to this, I mean, I think echo has a virtue. As you mentioned, it brought the physiology of the heart. I mean, this is ecophysiology. Now you can speak about physiology of the heart almost in real time. I mean, look, you can test things in real time. You can decrease PEEP, you can give a fluid challenge, you can whatever. But I mean, it's the info that it provides, it's amazing. And it has nothing to do what we did in the past. Just an example, just an example. We were very proud in the early years. I mean, let's say in the early 2000s with Ricardo. Ricardo was there. He was just a resident at that time, late maybe in that decade. We put a lot of dobutamine. We put dobutamine, we have data, we publish data, and this was data were in concordance with other groups in 50%, 50, or even a little bit more of the septic shock patient, without just a sort of faith-based medicine. If we had a higher cardiac output, we could, blah, 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 improve tissue perfusion, let's say. But also because some data, some very, very poorly scientifically grounded data that told us even dobutamine in low doses improves microcirculation because of vasodilatory effects, etc. Maybe it's true, but we gave in 50, 60% of the patients dobutamine when they did not rapidly reperfuse. And when we look at the data of Villia-Baron, Guéry, etc., and now data, maybe we did harm in patients with normal heart function, in patients, of course, in patients with hypovolemia, of course, I mean, and of course, and I'm sure of it, in the hyperkinetic patient. I mean, we have a paper, in 2013 with dobutamine as a crossover study, blinded, and we did no effect in hyperkinetic patients, even a little bit increase in oxygen consumption of the heart, no effect in microcirculation, nothing. So, I mean, nowadays, we use dobutamine in 10, 15% of septic shock patients guided by echo, as we did in Andromeda. You show very nice data. So I'm so pleased of the progress. Sometimes I think young people here in the audience, they don't realize this progress in the last 20 years. I mean, now we start physiologically oriented therapies guided by echo. And I don't care. I think it's not okay to start thinking nowadays. No, I am against. I will be more honest. Totally against on designing, planning a randomized controlled trial, echo versus no echo. I mean, or echo guide, no. I mean, with the info that echo gives you, provides you, is like a trial with arterial line, invasive arterial line versus not. I mean, a pulse oximeter or not. I mean, this is my opinion. So thank you very much.
So thank you, Glenn. Yes, maybe 2 points. First of all, I think what we have not mentioned so far is that our thinking is that we, for the phenotyping and for the rapid hemodynamic assessment, I think basic skills are enough. As you said, and I think, Glenn, it's not too late to learn about echo at every experience stage. So, because I think basic skills are enough. Of course, there are people that go the EDAC pathway with advanced critical care, and of course, you in some patients, very complicated patients, you need advanced echo skills. But I think for the majority of our patients and for the phenotyping, for the classic phenotyping, basic skills are enough. And I think it's important that we really teach our young doctors when they go into intensive care and learn intensive care, that they grow up with echo at the bedside, because echo is important. It answers questions, and I think that should be incorporated in their training. The second thing is that, and I think this, in my opinion, was one of the most important slide about what echo really does. because many people forget about that. Of course, echo can identify, can measure, but at the end, it's a tool that gives us confidence at the bedside. And it integrates and validates what we really measure. And if this is consistent with the hemodynamic or overall situation of the patient. And this is, for me, the most important thing. When I'm at the bedside and I hear about the history of the patient and I look at the vitals and everything else, and then I do the echo, it's always this validation loop in my mind. And everything I see, I would like to integrate and see if there's consistency with all the other things we measure or we learn about the patient. And then we increase confidence, what we really do and what is the most important therapy in this situation. And I think this is often forgot because people think they would like to get new information from echo, which is of course true and important, but echo is a tool of validation. It gives imaging to our numbers and imaging to our clinical conditions.
So it's sort of like a Bayesian thinking. You have some priors and you update it with what you get on the image, what you get on the bedside. That's an interesting way to think about it.
Ricardo, what do you think about that? Do you agree?
Thank you, Oliver. It was a wonderful. I couldn't stay here from the beginning, but congratulations for your wonderful lecture. I completely agree what you said, and I would like to say that I liked Swan guns, but what I like foremost from the Swan guns catheter is the ability to measure pulmonary artery pressure for me continuously. But now we know that if we face a difficult weaning in a patient with heart failure, we have another tools, fluid responsiveness before facing spontaneous breathing trial and things like that. So it's very interesting as we have tools now, but I want to highlight what you said at the end of your comment recently. I don't like the echocardiography, just to think what happens without any prior, without any suspicion, without just only to see, oh, the patient is hypotensive, it's not well perfused, hypoperfused, boom, the transducer on the chest. No. We have to think. As you said, we have to think the blood pressure, diastolic pressure, everything. It takes a minute, 30 seconds. But after that, you can confirm or not with the transducer, but not as the first approach that I have seen that as a first approach. Oh, let's put the echo in the transducer. Oh, wow, it's this and this and this. So I think it's very important because we can kill physiology with a rush on use a transducer. And I was in between no echo and echo, so I didn't learn. As Glenn. I'm not so younger, but I am younger than Glenn. So I would like to know. But it's very encouraging from you to hear that we still can learn some basic skills. I think it's not complicated. But that's what I wanted to say. And again, thank you for your wonderful lecture.
Yeah, thank you, Ricardo. And I can highlight or emphasize what you said again. When we teach our young doctors or when we provide courses, we also always say that echo is not an overall screening tool at the bedside. When you take the echo probe at the bedside, you have to have a clear idea. You have to have clinical questions that come up from the condition the patient is in and from the medical history, and then you can come up with questions, and then you will think about how echo or lung ultrasound or other ultrasound modalities can help to answer this clinical question. And I think this is very important. Do not apply echo to everyone. It's not an overall screening tool. You really need to have a clear idea and to have a clear question on echocardiography.
We have a question from the audience. Raquel asks, she says, very interesting, congratulations for the lecture. How can you difference, what are the key determinants that difference hyperdynamic and still hypovolemic patient? How would you discriminate these two groups?
Yeah. So when we scan these patients and when we assess LV systolic function, they are very similar. So both patient populations have a increased ejection fraction, but when we measure flow using LVOT VTI, the hyperkinetic state patient have a normal or supranormal LV VTI, so normal or supranormal stroke volume, whereas the still hypovolemic patient have usually decreased stroke volume. And when we test fluid responsiveness in these patients, the hyperkinetic state patient will not be that fluid responsive, and the still hypovolemic patient will highly be fluid responsive. Another thing, what I can recommend is to use the parasternal short axis view, the mid-papillary muscle view. And there you can assess the end diastolic area in the short axis at mid-papillary muscles. And if you have an area of more than 10 centimeters square, that can give you idea that you have enough volume. So this will be then a patient that is, or it gives you more confidence that is a patient with hyperkinetic state, which is not fluid responsive. And the still hypovolemic patient will usually have a reduced end diastolic volume. So end diastolic area of less than 10 centimeters square. Of course, they are overlapping and it's not a very good cutoff, but it also can be used in your clinical practice to strengthen your idea about the still hypovolemic or the hyperkinetic state patients.
Thank you very much, Oliver, for this answer. We have a hand up. I think Daniel Valenzuela wanted to ask something.
Hola.
No. Sí. Daniel, go ahead, please.
Hello, Oliver. Thank you very much for the lecture. I have two questions. The first is about right ventricular failure definitions. As you show, it's very nice videos. You show that right ventricular dilatation also associated with paradoxical septum motion. So it's clearly acute cardiopulmonary. But this is the definition for acute cardiopulmonary and sometimes have some repercussion in hemodynamics, others not, based in the intensity of the intraventricular interaction. Yeah, but the current recommendation phenotyping of the right ventricular dysfunction, it could be more simple than that. It's like a right ventricular dilatation associated with PVC more than 8. We know that about 1/3 of the patients on mechanical ventilation have right ventricular dilatation because of increasing afterload, for example. Not necessarily have right ventricular failure. And other definition are right ventricular dilatation more than 60% of the left ventricular and diastolic area, or associated with TAPSE less than 16, or a fractional area shortening less than 35%. So in your current practice, you know that there are different definitions. What do you use and what do you think on these different things? Because as you show, also one of the definitions was associated with normal VTI. So it is a failure, it's a dysfunction, right ventricular dysfunction. This is the first question.
Yeah, so thank you very much for this very, I say, very important comment. And it's very difficult. I say it's very difficult. At the moment, there's no consensus about the definition of right ventricular failure. So this is one of the major problems. But I think if you go more into the detail and the pathophysiology of right heart failure, you will see, and this is what you mentioned, we often have a pressure overload on the right ventricle. And what I do, I also think in phases. and in pathophysiology steps. So the first is that you basically have a homeometric adaptation phase, which means if there is an increased afterload, the right ventricle will start to increase contractility. And this is often even seen by increased RV parameters such as TAPSE. And this is a very early state. And it's called homeometric adaptation because only the contractility is increased, but the ratio of the right to the left ventricle is still normal. Then, if you do not solve the problem and the patient got worse, you do not solve the problem of the increased pressure overload, then the adaptation of the right ventricle will go further, and the next phase, which is the heterometric adaptation phase. And in this phase, the right ventricle starts to dilate. And the right ventricle is very clever because the ventricle starts to dilate to deal with this pressure overload. And if the right ventricle dilates, it increases right end diastolic volume and therefore uses Frank-Starling mechanism to maintain stroke volume and to maintain RV to LV, RV to PA coupling. By the dilation, you also get a functional tricuspid regurgitation, where you have then a pressure release in the right atrium, and that prevents the right ventricle from further pressure overload and that the patient will immediately die. If the right ventricle would not adapt, the patient would die at this stage. A third mechanism at the homeometric adaptation phase is the right ventricle starts or increases heart rate. We usually see these patients in tachycardia, which is also an adaptive mechanism to maintain cardiac index or cardiac output. If you then do not solve the problem at this stage, then you go into the last phase, which is RV to PA uncoupling. And then the patient will die if you do not treat and solve the problem. Coming back to what you asked me about the definition and the problem that according to some definitions, RV failure is defined by the dimensions, the RV to LV ratios. And then on the other hand, we have the functional assessment of systolic RV systolic function given by TAPSE, fractal area change, or whatever. I think it is important to incorporate both in my thinking at the bedside. The RV-LV dimensions and the ratio gives me an idea about the adaptation phase of the right ventricle in these patients. But I also incorporate systolic measurements such as TAPSE, and I think TAPSE is a very, very powerful measurement. There are, of course, many people that argue against that because they say it's just one of the components of the right ventricular systolic fraction. And it just displays the longitudinal component. But we have some very good data in patients with pulmonary hypertension when invasively the RV to PA coupling was measured and plotted against TAPSE. And there's a very, very good correlation. So basically, the TAPSE, the longitudinal function, is not a measure of intrinsic contractility of the right ventricle. It is more a parameter that reflects the RV to PA coupling. And I think this, when you know this, then TAPSE is again more and more interesting to be used at the bedside, because when I see a right ventricle that is dilated, but I still have a normal TAPSE, then I know this patient is not yet into uncoupling. Okay. And this is what I do as a validation at the bedside, incorporating the dimensions and measurements of the systolic function. But I overall agree with you that there's no consensus about a real definition except for acute cor pulmonale. But I think it's not that difficult, because as you see, there are phases of adaptation. And I think when we treat patients with RV failure, these are very complex patients. And I'm not sure if we can capture these patients and classify with one definition. I think even in the future, we will have to do the risk assessment and use echo and everything else to ask ourselves, what is the adaptation phase the patient is in at the moment, and how can I help the patient at this phase? I'm sorry for this complex answer.
I think we have time for one small question in the audience. Is Rashawari asks, does low LV ESV reflect hyperdynamic, and does low end diastolic volume reflect low preload in your experience?
Can you repeat that, Eduardo?
Does a low LV end systolic volume reflect primary and hyperdynamic state? And does a low end diastolic volume reflect low preload?
So low end systolic volume can be everything. So low end systolic volume can be RV failure because of the ventricular interdependence. Patients with RV failure always have at least normal LV function, and often have a very low end systolic phase because the RV is dilated and the septum is pushing. So it can be that. It can be a hyperkinetic state. It can be still hypovolemic. It can be other different types of shocks, such as a normal hypovolemic shock. So I think end systolic volume is not an ideal parameter, because there's a huge overlap, and it's shown in different phenotypes. The more important thing is the end diastolic volume in the personal short axis that may help to differentiate it between a normal end diastolic volume and, as I said, the area of more than 10 centimeters of square in the personal short axis at mid-papillary muscle level can help you to exclude patients that are massively hypovolemic. If it's more than 10 centimeters, like 14, 15 centimeters, usually the ventricle has enough volume. And this is then more a patient that is in a hyperkinetic state than still hypovolemic. But of course, I would always do the test of fluid responsiveness and do not rely only on these static measurements.
Perfect. Thank you, Oliver, for this wonderful lecture. It's been very enlightening for all of us. I think those that we're not so experts in echo, and those that are also more fun to hemodynamic monitoring with echocardiography. I think this was wonderful perspective, very embedded within the physiological rationale, and very updated with wonderful papers that I saw many people taking screenshots to search for them later. So thank you, my friend. Thank you for being with us here.
Thank you so much, guys.
And for everyone, this colloquium has been recorded, so we will upload it to our YouTube channel, so you can enjoy it later again at home. So wonderful to see you, and enjoy your vacations on Saturday.
Thank
you. Bye-bye.
Bye, my friends.